Well, I am. And then we will bring for them around. Yeah.
Yeah, I'm the same way. Good morning. It is September 23rd. We are here with Chad Abbott from Transplant, and we're ready to get started. There's no PowerPoint today. We're just talking for discussion and a handout. So we're going to go ahead and get started.
Oh,
Okay, guys. You can turn your attention. This is Chad Abbott from the transplant team. He's a registered nurse. What's your other title? Yeah.
Certified clinical transplant coordinator.
Certified clinical transplant coordinator. Official.
Yeah, I'm not official.
he's not.
A little more laid
Don't worry.
back environment today. There's no PowerPoint, but he just came to discuss things with us, just to try to troubleshoot some of the maybe pre-op questions that we have, or anything that comes up that we get held up on with our transplant patients. So you can see we have a few handouts. If you didn't get one, grab one, and then our sign-in sheet is up here. So all right, take it away.
Good morning. Thanks, guys. Regarding the handouts, if Margaret does have the handouts, I emailed them all to her.
Oh, good.
If you want to distribute them to everybody,
Are these yours?
those are yours.
Okay,
These are
that's what I
mine.
gave everybody. Perfect.
So a couple of basic things. I just thought I'd give you kind of an overview of our transplant activity. Obviously, you guys see the people come in, but may not know what all the numbers are. So I thought I'd talk about that, and then I'll kind of talk about the blood type or the blood orders that need to be done in pre-op. That's a key thing. So that's the one thing I want everybody to be keyed into. And then just a little bit about kind of the surgery and the recovery, so you know what these donors and recipients go through. So talking about our kidney patients first, we've got right now, as of this morning, 789 actively listed recipients. We follow about 1,400. So at any given time, about 40% of our list is inactive. In 2000 or to date this year, we've done 117 deceased cases, and we've only done 41 living cases. If you look back at 2019, we did 124 deceased. So the deceased numbers are way up. We did 81 living cases. The living numbers are way down. And that's something that we put a lot of effort into. There's a couple of reasons for it. One is COVID. That's probably a big reason. The other reason is people just aren't that healthy. So to date, we've had over 1,000 living donor referrals. Those are people who just call us to say they're interested in transplant. And that's generated 41 living cases. So you can see the turnaround is not very good for that. So we've done a lot of stuff to try to fix that, but I think it's just the reality of where we're at in this day and age. You guys probably know this, but our recipients wait for a deceased donor an average of 5 years. During that 5 years, we typically only see them once a year. So if you see these people when they come in and you wonder, why does this person maybe not have a real good grasp on what's going on? A lot of it is because A, we haven't seen them. We do keep in touch with them. And B, they're dealing with a lot of other issues. The majority of them are on dialysis. I would tell you, if at any time you worry about a recipient, don't hesitate to reach out to somebody and say, I've got concerns about this person, and whoever you speak with should be receptive and should be listening to you. As far as the evaluation, I kind of mentioned the recipients do the majority of their testing locally. The majority of them don't live in Ann Arbor. Most people don't like to come here to do testing. I'm sure, as we can all attest to, with how difficult it can be to navigate sometimes. They do a lot of testing, but like I said, the majority of it is done locally. As far as the donor testing, donors should not seem unprepared. So again, I would encourage you, if you see a donor who is even in pre-op seems to have issues, then by all means reach out to someone about them. The donors do a lot of pre-testing before they even get to us as an evaluation. Just real quick, their evaluation includes a lot of labs, chest x-ray, EKG, a CT scan, and then they're seen by nephrology, surgery, and social work. At a minimum, a donor should have been here at least 3 times prior to donation. So they should be pretty well informed and engaged into what's going on. As far as the procedures, most of you probably know the recipient procedure is always done open. It's generally an incision above the iliac fossa. They usually try to anastomose to the iliac artery. At times they will use other targets because a lot of these recipients have a lot of calcifications from dialysis and stuff, but that's the general approach. Our recipients stay in the hospital on an average of 3 to 5 days. So they're in and out pretty quick. They generally go to 5C following the procedure. It's rarely that a kidney will go to the ICU. As far as the donor procedure, it's almost always hand-assisted laparoscopic. When they used to do an open nephrectomy, does anybody remember open nephrectomies? Okay, so you know that's a big incision in the back. You know, the hand-assisted laparoscopic is a midline. In the majority of cases, it's a left nephrectomy. Does anybody know why it's left nephrectomy? Perfect, I'm gonna tell you something you don't know. It is Go ahead.
No, I don't remember. I know there's a reason why, but I don't remember.
So they like to do a left nephrectomy because the renal vein is longer. That's why even in deceased cases, we like to take the left if at all possible. There are some centers that will not do a right kidney, some of the smaller centers. The renal vein is longer. That's why we like it in both deceased and in hand assisted. The other reason is you can avoid everything that's over on the right side, all the liver stuff. So there's less chance for surgical injury. There are also a fair amount of centers that won't do a right nephrectomy. And we even have some of our surgeons here that if they haven't done one in a long time and it's a right, then they'll pass it on to a different surgeon. You know, like Sung has done a lot of them, Woodside, Punch. Those are the 3 main surgeons, as you know, that do these. But I would say probably 85 to 90% of our nephrectomies are right nephrectomies.
Yeah.
Our donors are generally in the hospital for 1 night. So they go to the floor, they're up the same night walking, up the next morning, then generally gone the following afternoon. In certain cases, they will stay for a couple of days, and if they want to stay, then we'll let them stay. But in most cases, they're in and out in 1 day. We used to see them post-op at 2 weeks. Now those are done by Zoom. And I don't foresee that going back to in-person just because we don't have to see them. You know, they do very well and they don't have to travel. Again, the majority of them don't live local. They drive 2-3 hours for a 15-minute visit. So the follow-up is pretty much all done by Zoom. Questions about that, surgery, stay for donors, recipients, anything? That's all pretty straightforward. I've been doing this since 2005, and that really hasn't changed in 16 years. Margaret asked me to talk about the difference between living and paired donation. Obviously, you know what living is. It's a living donation case. Paired donation is when people are either blood type or HLA, meaning that when we mix a donor and recipient blood together, the recipient shows a reaction against that donor. Since 2008, which is when we started doing paired donation, we've done 178 cases. That only counts recipients. That doesn't count the donor cases because there are times that we do a donor case and we don't have a recipient at that time. 69 of those have been internal. When we first started this, we did them all internally. So not we, because I had nothing to do with it, but U of M developed an internal matching software where we would just try to match U of M people. So I mentioned we've got about 800 people on our list. At any given time, we've only got about 12 pairs that are active in paired donation. So it's not a real high volume of people. I can't really explain why we don't have that many people in pair because we have a lot of incompatible people. But that seems to be the average across the country. And we're actually one of the bigger pair donation programs throughout the country. So in pair donation, pretty much everybody in the country participates in it now. And we've done transplants from as far, California to the East Coast down to Florida. Very few of them involve our internal pairs anymore. And I can't remember the last time you guys would have seen one of those. Just so you know, with the internal pairs, we always do keep them separate. They don't know each other. So that's when I usually send a message just notifying everybody, I'll send it to, I was sending it to Marianne. I guess I can include you on it now, right? You, Tricia? The more people that know, the better. When we first did one, we had an internal case where a donor was here and it was a non-directed donor, which we'll get about 2 or 3 of those, just people who say, I just want to donate a kidney. I don't care who it goes to. Somehow they ended up next to each other, and obviously they heard each other talking, and when the donor wheeled out, the recipient said, thank you, which, isn't ideal because we don't like them to meet until about 3 months after, just to give them time to, digest everything. There's a lot of emotional stuff in this. We did a case a couple of years ago where a recipient here got a kidney a recipient here that was non-directed donated to Swedish, which is in Seattle. And somehow they found each other before surgery on a Facebook kidney donation page. So they were communicating beforehand. Nobody knew that. And our donor has not done well at all. It's got nothing to do with physical things. It was all psychological. So it was not a good outcome. The recipient posted on Facebook that they were thankful they got this kidney, but it wasn't working. So you can imagine I'm a non-directed donor. I get this kidney and then I find out it's not working. It ended up working, but our donor has been in and out of the hospital for months after this. So it's just another reason why we keep them separate. We don't want these people to meet beforehand because of things like that. So I mentioned we've done 178 paired cases since 2008. Last year, it dropped off significantly because of COVID, because a lot of centers shut down. We started up much sooner than a lot of places. Some of them even shut down for a little bit earlier this spring, which luckily we didn't have to do. It makes up about 1/4 of our volume. So any given year, we'll do about 80 living cases. About 15 to 20 of those on average are paired donation cases. I think we'll see that increase now that everybody is doing them again, and we've generated a lot of matches. Whoever worked yesterday, we sent a kidney yesterday to New Jersey. Perfect.
I had the donor.
You had the donor? And she had done well. When I looked last night, it looked like she was doing great. She should go home today. And we're doing another one next week where we're sending a kidney to Wake Forest, and we're going to get one from Vanderbilt. The donors and recipients in paired donation always stay at their local center, so they do not travel. The kidney flies. So luckily, flying kidneys, we've never not had a kidney make it. We did have a delay in one, which is one reason why I wanted to talk to you guys about this, because it was nobody's fault in pre-op. But we had a delay in a kidney where it missed the flight, and it added about 4 hours of cold time to the organ, which isn't a huge deal to add that amount of time. But it's a huge deal when the outside center is planning on it being there at 7 and it gets there at 11. And we actually ended up paying $20,000 for a charter to get it there earlier because it was our fault. So there is kind of a time frame on these paired cases where we've got set pickup times where they're going to make a flight, and it's important that we get it. The reason that kidney missed a flight was because the blood specimens that I'm going to talk to you about didn't get drawn in pre-op, then anesthesia couldn't get the blood draw. After the OR, they had to flip the patient, and it added about an hour delay, and that's why we missed the flight. Talking a little bit about liver recipients and donors. Right now, we've got 62 people active on our liver list. A lot of that is because we transplanted a significant amount of that list earlier in the year, which I'm sure you guys are all aware of how busy we were. It's kind of declined a little bit lately, and a lot of that is because we did transplant so many of our sicker people. To date, we've done 64, 62 of those are deceased. We've only done 2 living livers this year, as compared to 7 in 2019. I'm just throwing out 2020 because they don't really matter. We do have a couple of more coming up. There's going to be one October 12th. It's a dad donating to his son. And then we're going to do another one November 30th, which is a friend to a friend. So we'll probably end up with 4 this year is my guess. As far as the living donor surgery, the majority of those are right hepatectomies, or right lobe donations, I should say. The reason for that is what you probably know. The right lobe is bigger than the left lobe. In most cases, the recipient needs the right lobe in order for it to work. Generally, the times that we can do left lobes are in pediatrics. And we've only done a few pediatrics. A lot of that is because our peds list gets transplanted quick. And there's usually only 1 or 2 active peds on the transplant list. Our living donors, they go to SICU post-op. They're generally in the ICU for 1 day and generally in the hospital for, I think our average is around 4 days. It's about 4 to 5. The main reason that they're in, we watch for a bile leak because that's one of the big complications with living donor surgeries, and then pain control. I'm sure you know they do the tap blocks on the living donors. That seems to work really well, and their pain is generally well controlled. They're usually up the same day walking as well. Our living donors, we've done 23 since 2016 when Dr. Sonenday kind of restarted the program. He has a big initiative to increase living donation. And we're starting to do a lot more marketing that both publicly as well as talking with the recipients about it. So my guess would be that you'll start to see more living liver donor surgeries. And hopefully we'll get it in that, 10 a year range. I think it's kind of a realistic goal. About 75% of the living donors return to work at 8 weeks. So they do heal pretty quickly. The liver regenerates typically by about 10 weeks. All right, talking about the blood specimens, because this is an important thing. It is a UNOS, which is United Network for Organ Sharing requirement that we obtain these. So the big thing to remember in pre-op is every recipient that comes into the hospital, whether it's living or deceased, should have blood specimens ordered. If they're not ordered, then you should reach out to either the STX APP or if it's after hours, the intern on call. But you should always be getting a specimen on a recipient. And that's per UNOS guidelines. All living donors also need specimens ordered. So if there's not something ordered, reach out to the APP. You can reach out to me because I'm generally always here during the week. We have to store donor specimens for 10 years. In the recipient one, and this is on your sheet, I gotta look at it quick. Put my glasses on. So the first one, you can see that all living donors, it should say pre-op specimen, or it should say HLA donor store, I'm sorry. So those specimens are for hepatitis and HIV testing, and we have to store those results for 10 years. The reason for this is so if a recipient develops HIV or hepatitis post-op, they can go back and retest the specimen. Even though we're required to do donor virology testing within 28 days of any surgery, UNOS just implemented that we have to store those for 10 years. So again, every living donor should have something drawn. The recipients also should be drawn on admission to pre-op for HIV and hepatitis studies. So if you don't see them, then somebody didn't get them ordered. The APPs are very good about getting them done, but I could see that being an issue after hours with the recipient coming in. Again, if we don't have those, then we get cited by UNOS. If you get cited by UNOS, then UNOS can shut you down. So it's kind of a big deal. And we have had a couple missed, again, not your staff's fault. That was on us for not having them ordered. But just something to remember. For paired donation, every paired donor, when a kidney is being shipped out, we have to send blood with the organ. And the reason that we have to send that blood is it's used if the kidney gets to an outside center and for some reason that recipient can't receive the organ, they need to be able to match it with another recipient. Because in most cases, we're not going to get the kidney back. It's just, it's too much time going back and forth. It's generally going to be a purple top and then 3 yellow tops. It's not the yellow tops that you would use for like a comp. So they're actually like a pale yellow. And I know somebody put together some kits. I don't remember who. Andrea.
Free of charge for skin.
Yeah, it's generally 3 yellow tops and a purple top. If those aren't ordered, that's on me. So page me if that is the case.
And that's the living
What, those are paired,
here.
yes. Uh-huh.
So if they're pre-op, let's say you come in and they pre-op on one of those floors, are these labs to be drawn then when we're doing all of this stuff upstairs, and then we put it on if they came from the floor down here?
They should,
But
yeah, like a pre-op recipient, yes. It's mainly for the living cases that you guys are gonna deal with it. But if it's a deceased case and they're pre-opt upstairs, then they should be drawn upstairs. They have to be drawn within 96 hours of transplant. So somebody had a question about the paired specimens.
no,
It's 0258. It's on the order. Like when I put it in, it's actually on the order that if there's a question to page me.
If one of those orders were missed, like that, it wasn't.
It's going to be by my last name. It's not going to be on transplant. Yep. But I have it on. You mean if it's not ordered?
Like if it wasn't ordered at all,
Yes.
and
Then
we catch it and say, we're like, oh, we have to have a specimen on.
then it's Abbott, Chad. Yep.
Yeah.
And it's 025. I did not put that in the handouts, but feel free to distribute that. Probably against my better judgment.
Well, I'll be
0258.
Well, I'll be taking down.
Yeah, because I do all of the paired cases. And I generally won't schedule a paired case if I'm not going to be here, just because so many things can happen. And those are planned well enough in advance. But that's the key thing, is to remember they should all have something ordered.
And I just want to clarify.
Yep.
On the order set here, it says a red top and 3 yellow.
Did I say purple? I meant red. Sorry, it is a red top and 3 yellows. Yes. There are times that centers may want something else. They can do what they need with a red top and 3 yellows, but that's a safe thing.
Those green top trees. Because they come, sometimes they come with the green top trees that are in the bag.
The transplants do?
Yeah, I'm not sure if it's for me or
Isn't that a green? Well, is it dark green or light green? But
dark.
I don't know if that's a different study.
That might be a study, because that's not anything
that's
that,
not
it's
you.
not anything that we would be ordering. No.
All right.
With the paired donation cases, it's helpful if it's drawn in pre-op for the reason that I mentioned, because once they get in there, it's not going to get drawn. That's not their focus, and that's why the one was delayed, because it didn't get drawn in pre-op, and the patient ended up going back early. So we always want those drawn pre. And Gift of Life, comes and does all of our perfusion for the paired donation cases. They're well aware of this. They're supposed to be getting here early enough to make sure that the specimen's been drawn. And I know that they were here yesterday or before that, and they made sure that it was drawn.
On night shift, we tend to get a lot of those early kidney cases that we come down early, but usually all those are admitted. And most of them I've seen that come through on nights already have their labs drawn.
Right.
Is that the case mainly, that they're usually admitted, the night before?
Yes.
Okay.
So for deceased cases, they should be drawn on the floor because they rarely would just come directly to you guys. Now the livers.
In the ICU, right? While they're maintaining them. Is that correct?
For kidneys, not usually.
No, that's right.
Even the livers, you know,
They don't
very,
go to the ICU pre-op, they don't
Yeah.
go until after.
yeah,
But I mean, so a deceased person that you're taking the organs from would be in the ICU, so most likely.
Because they're on the ventilator.
those would, yes, in a deceased, if we have the deceased donor here, yes, then they should take care of all that stuff. Yep.
Does it usually come from a donor here?
No, it's,
A lot of them are outside, especially the livers. UNOS changed the allocation system earlier this year. You know, it used to be, it was for, you know, like Michigan, Ohio, Indiana was our region. They opened it up, I want to say to 500 miles. So we get a fair amount, like Wisconsin. They're traveling a lot more for livers. Pittsburgh is included in it now. You know, we didn't used to get those organs, but now we get them. So a lot of our livers now are flown in as opposed to the, Yes. Yeah. It is.
So many have been canceled lately.
We've had people, I know my daughter works on 5C and I think one guy got called in 12 times
oh,
before
Yeah,
he,
that got called in for her 16th time. It was on her birthday. She got sent home.
yeah, they're, you know, Dr. Sonenday's well aware of that and they're, you know, they're trying to figure out ways to not bring people, but sometimes you don't have a choice. You know, if somebody lives, like the one guy lived in Marquette, he's got to come down because, you know, you can't wait until you look at the organ, you know, for a liver. Now a kidney, yeah, you can wait a little bit, but
how much time do you have for a liver?
a kidney, we've had them have cold ischemic time up to 30 hours.
Wow.
It's not optimal, but that's usually if we're getting a kidney from a long ways away. Kidneys are generally local, although they've opened up the kidney allocation too. So we've gotten a lot more from outside centers. But there are times that it's called a perfect match. It's not really a perfect match because there is no perfect match unless it's a twin. But it's a zero mismatch, meaning all their genetic typing markers match. We'll get those from a distance away, like California. California flights are horrible. And you know, those will have some long times up to 24 hours on them. You know, livers, they generally like to get those in less than 12 hours. I mean, so that's why these people are here and they get sent home. But that's definitely created some inconvenience for people. But those recipients are well aware of that when they're listed, that this is the reality, and that this might be the case with everything. Yeah. Other general questions about stuff that we do that you wonder why we do it?
Cadaveric kidneys take so long to wake up after surgery? Is it sometimes based on the times that they've been?
It is. Yeah, it's some of it. It's called delayed graft function. And typically the longer an organ's out, then the longer it takes it to wake up. They do. A fair amount of them end up on pump now. A lot of that's based on donor criteria. If you get an older donor, they'll usually biopsy them and then put them on a pump. But a lot of the younger donors, which we see a fair amount of, you know, a lot of our, because you guys don't hear about the donor. One good thing about the opiate crisis is it's created a lot of living donors, because they're, I mean, it kind of sounds grim, but they're young and they typically die quick. And they don't die at home because they get them to the hospital. That is a fair amount of our, you know, donors nowadays, especially for kidneys, because it generally doesn't affect the kidney, you know, because they still got flow.
Recipients of disease donors, do they ever interact with the family? Because I've had so many people like ask on the floor, like,
Mm-hmm.
can I meet whoever's family member and stuff? Do you guys ever connect them?
Yeah. For living, we as coordinators will handle it, which is usually me because I usually do the paired cases. We ask them to wait 3 months and then we have them sign a consent for exchange of information. And it starts off with a generic conversation where I'll ask them, they'll send it between the coordinators. And we ask them to be nondescript and just say, they can give their first name, say thank you, or however they want to do it. For deceased, it always goes through gift of life. So if they want to meet, then the recipient team on the back end will connect them with Gift of Life, and then they can meet. I don't really know how many asked to meet, but I would think there's fair. Yeah. Right, and they can, yeah, the best thing to tell them is talk to your surgeon and their recipient team afterwards, and then they can help facilitate it.
I saw something interesting on the news. It was supposed to be a feel-good story, but it kind of surprised me. Is this gal shows up at her, it was her like in-law somewhere. I can't remember exactly what it was, but she said, "I'm your kidney donor." Knocks on this guy's door. They open the door, and here's this gal with this sign, right? And I was like, I thought all that was supposed to be arranged. They were all surprised to see him. And
Mhm.
I don't know if it was staged or not, but because that's what I thought, but that all had to be arranged. And
Yeah, I mean, we can't,
surprises aren't always good on that stuff.
no, they're not, for the reasons that I kind of mentioned
Yeah,
before.
exactly.
You know, we preach it to the non-direct donors, especially that you may never hear from this person. And a fair amount of people don't hear. You know, we had one guy who donated, this has been years ago, but he was actually one of our mentors. We have a lot of peer mentors that meet with donors and recipients before transplant, and he was non-directed, donated. And he actually donated to a person here whose wife was going to donate, and then it ended up that she couldn't donate, and he never heard from the person, and he pretty much just withdrew everything because he was just upset that he never heard anything about it. So we do really tell them, you have to just do this knowing that you're doing it to help somebody, and you may not hear from them or ever meet them. But, yeah.
With the new treatments for Hep C,
Mhm.
has that broadened the criteria or?
Absolutely. Yeah, absolutely. You know, we can take the Hep C organs now, they'll treat them afterwards. Fortunately, a lot of the people are getting treated ahead of time. The same thing with Hep B. You know, we'll take the Hep B organs now as well, and then they can treat the recipients. So yeah, that's made a huge difference. For sure.
Don't they, I know before they would try to like match, like if someone already had Hep C, and they would give them like a Hep C liver, because they would, chances are they would get a liver quicker.
Mhm.
So
Yep.
are they still doing things like that?
Yep, they are. They can send them for it.
I used to work in SICU, so.
Okay.
Yeah.
You would see those, yeah. That was my old grounds way back when.
It was way back when. That's when
Things were getting old.
I don't. When your daughter, you said your daughter's on 5C, I'm like, oh man.
She was born when I started in the SICU. Yeah. Yes. Other questions about the process? About,
Any other practice things that we need to clean up, I guess? Anything we can do to help you guys?
I think it's good. Like I said, the way yesterday went was perfect. They were ordered. Somebody called me, made sure that it was the right thing. That was perfect. It's better to ask and make sure than, you know, to think,
Yeah.
because it's hard to get it done afterwards.
Well, how come you guys don't have someone like a coordinator to come and assist with that in pre-op? I come from a different
Uh-huh.
system from Henry Ford, where we had a coordinator coming from each patient we have, making sure this was done.
Mm-hmm.
How come you guys don't have that? Because we work with kidneys, with OBGYN patients,
Mhm.
with kids, with everything, and it's super easy to miss one thing. And I know it's super important to you guys.
Right.
How come you don't have?
That, especially with the paired. The other blood draw. The APPs see the recipients and they check on them in the morning. So the APPs should have the recipients and they're looking at the orders. As far as the living case,
Sorry.
the PAs and the MPs.
Oh, okay.
Sorry. Yeah, they're, you know, they are here and they do check on all of the recipients in the morning. As far as the living donors, because this is fairly new, I did used to come down for the paired donors and make sure it was done. And then it never was an issue until the last sample happened. It's one reason why we've asked Gift of Life to come in. I'm certainly willing, I mean, I'm here to come down in the morning for the paired donor cases and make sure that things are drawn. When I used to come down, it was so hectic, I just added another person and it added to the chaos, and I didn't feel like it was real beneficial. But I mean, if you guys think it's something that's needed, then I'm happy to, more than willing.
You know, a lot of like, we have a really high turnover
Mhm.
and a lot of people, a lot of newer people, and a lot of people moving up to the earlier shift, like,
Uh-huh.
so.
And not everyone comes from
Maybe it
CQ like we did. A lot
might
of
be a
people come just with
good idea.
telemetry experience.
Mhm.
I have a patient that was really critical of liver transplant, and the coordinator would help me with the process.
Okay.
And the kid is really sick, and the brother donated his liver.
Mhm.
And I had to draw blood. I had to make sure it's matched with the brother.
Mhm.
And it was a weekend. I was just coordinating with the coordinator. It was really fast that she helped me,
Mhm.
and it's a weekend, and that's why it's probably important to get a coordinator to help us.
Okay.
Even if we just start with just knowing that you are available, like now that we know him, that might be a start. And then if we
Mhm.
need to have you come,
Yeah, I'm more than willing to come down and just
Is
make
there-
sure the blood's drawn.
other coordinators that work with you then? Do you have a team?
We do.
Okay.
For living donor, we have 4 of us.
Okay.
The recipient coordinators really wouldn't have anything to do with pre-op. Yeah, the recipient coordinators shouldn't have anything to do with pre-op. We do take on-call, but the PAs and the MPs and the interns handle all of the deceased cases. Do you see an issue with deceased cases? With like being aware of stuff?
I mean, just night shift, there's a lot, because like you don't know what's been done, because half the time they're coming in at midnight, 1
Right.
o'clock in the morning, what have they had done?
Mhm.
Same things, feeds collected, I've had to call lab.
Okay,
Do certain ones,
Because
like,
they'll come from home
yeah.
and
Right.
then we just start from scratch where they need a shower and they need X-ray,
Everything,
they need everything.
And
Yeah.
don't forget, we have 3 patients at the same time.
Mhm.
Sometimes we have the donor and the recipient. And they used to like bring the families. They like to have pictures together. They want to make a big party.
Right.
Yeah, I think that's why some of this stuff gets
Making
made.
sure
Okay.
everything gets done, and they complain about every book that you do. And sometimes you do a good line, but won't give you blood. You have to call them again. Oh, this one doesn't know what she's doing. And you
Right.
get all of this stress, and then it's easy to miss. So I am surprised that here it's not done the way I'm used to at Henry Ford, when the coordinator was there with each recipient, each donor,
Mhm.
to make sure things were done correctly. So
Okay.
I would be happy if someone will come and assist us in pre-op.
Okay. I'll talk to the NPs and PAs about the deceased cases. We do all take on-call. Our on-call is done from home. We don't have an in-house person, but there is always somebody here for those. The living cases, we certainly, can have people here. Easy enough to make sure that stuff's done. Because those are all planned well in advance. Yeah,
How far in advance are they planned?
typically a month.
Run?
I would say it's very rarely that a living donor gets cleared and they're in surgery in a week or 2. It's usually about a month. Yeah. Other questions about anything in particular?
Well, thank you.
Yeah, if things do come up, feel free to reach out to me. Email me or talk to Trisha or Margaret and have them get in touch. And certainly work with people to try to make your job easier. We don't want to make it harder by doing all of this stuff, for sure. So. All right. All right, great, thanks. All right, you guys have a good day. Thank you.
Awesome, thank
Got my
you.
contact info.
Yes, yeah,
Comes up, let me know.
perfect.
All right,
We
thanks.
appreciate it. Is this your bag, Chad?
Okay.